I am Maddie Robbie, for those who don't know me, and I am the project manager for this project. And I was tasked with kind of guiding the conversation and getting the research started. And we were tasked by our client to look at ways to increase access to behavioral health providers in rural California. I like to see where I'm going when I start any presentation. So I outlined, pardon me, exactly what we're going to get into. So we'll start with an introduction that goes over the background information that it's been a long day if you can't tell. The background information that will prepare you well to go into the alternatives that my colleagues will go over. After they go over their alternatives, we'll kind of wrap up with a conclusion, go over the different criteria that we chose to evaluate all alternatives with, propose a solution, and then talk about its political acceptability. So our client tasked us with looking at ways to increase access to behavioral health care providers in rural counties. Our client was the Rural County Representatives of California, or RCRC, as I will talk about them throughout the presentation. Caroline over here is the communications director, and she was really vital in getting us started in our research. She provided us with some background information and talked us through different ways that our alternatives will have good or bad implications. Sarah, on the other hand, is more of the policy wonk. She is the one who guided us with specific questions in relation to policy questions that we may have and answers. She handles issue areas from healthcare to education to transportation. So what is our problem statement? I think it's important to understand and guide our framework when we look at this problem statement. We decided to focus on the fact that there are too many residents in rural California who lack access to behavioral health providers. This statement helped guide our research and walk us through exactly what we wanted to solve and focus back on the issue at hand. Excuse me. So I think going forward, it's really important to have context when you step into any policy alternative. And I pulled this definition of a rural county directly from the RCRC website. And I'm not going to read it to you because that would take too much time. So if you want to spend 30 seconds or so just reading through it, then I will go on to the next slide. While you read that, because I don't really want to sit here in silence for 30 seconds, I think it's important to understand that the term rural isn't a one-size-fits-all opportunity or definition. It depends on what county you're looking at, the demographics, the economic data, how populated it is, what the transportation and roads look like. It's really not a one-size-all-fits opportunity. So it's important to keep that in mind when looking at alternatives and solutions to the policy problem. So as I mentioned earlier, Carolyn was really helpful in guiding our beginning steps in our research. And she sent us this study, which I believe all read for class because Rob assigned it. But it was really interesting if you spent any time kind of diving deep into it. And we focused really on the behavioral health aspect of this study. And it found that counties with smaller populations that are further from their urban counterparts actually have the lowest ratio of behavioral health providers, which tracks if you follow what I'm saying. But one thing that I found really interesting was that counties that actually have a behavioral health education institution in them have the highest rate of behavioral health providers, and the neighboring counties have the second largest amount of behavioral health providers, which makes sense. You don't have to travel very far to get an education and then go back home and practice. Licensed marriage and family therapists and licensed clinical social workers, which are LMFTs and LCSWs, are the largest group of providers in rural counties, followed by psychologists and then lastly by psychiatrists. So psychiatrists are the largest need in rural counties. In fact, there are 6 different counties that don't have any psychiatrists present at all, which are Alpine, Glen, Modoc, Mono, Sierra, and Yuba. So it's really important that we focus on these counties and make sure they have the resources that they need. I am a big visual learner, so I like to see kind of what these geographic areas are that we're analyzing so that I can better understand the data. RCRC grouped the data by different county areas or different groups so that it's easier to analyze and compare data. So it's just a visual. I find it helpful to look at. Again, for visual purposes, I think it's really important to look at the map of RCRC's 39 member counties on the right, and then a graphic from the Department of Healthcare Access and Information, if I'm getting that acronym correct. The dark purple is where there's a geographic need or it's difficult to get into those areas based on geographic region for mental health providers. The lightest purple is where the population meets the demand for mental health providers in rural counties or in counties at all. And then kind of the middle-ish purple is where the greatest need is for behavioral health providers in California. So there is not enough providers to meet the population demand. And if you use your imagination just a teensy bit and try and overlap the two, you can see that RCRC's counties actually overlap with the middle purple color. And that's really helpful for me to see when I look at data. Alrighty, so that study found that there were a couple of barriers for behavioral health providers when looking to find a job in rural counties. First and foremost, there's a really, really lengthy hiring process. There's also an inability to provide competitive pay in tandem with county competition. And by that, I mean, if you can go get a job in Santa Clara County versus Tulare County, and you can get a job instantaneously, make six figures, and get lots of hands-on practice, or go into Tulare County, make half as much and rarely get any hands-on practice, you're going to go to Santa Clara County. It's pretty obvious because you make more money and get more hands-on practice. So there's that barrier. Background checks, as always, with any patient interaction. Lack of infrastructure for telehealth services, I think, is also really important. So looking at ways to increase broadband or Wi-Fi connectivity so that people can get access to providers. And then lack of educational opportunities in the counties. By that, I mean, in order to go and practice in a rural county, you have to go to school and move further out into rural counties in order to meet the needs of rural counties, which is difficult, as you can probably all attest to. When we're in grad school, we make connections and we build on those connections, and that's how we get jobs. And if you have to move after school, that's difficult. A couple of just kind of statistics is that there are no medical schools in RCRC counties, which is really, really difficult. Tulare County, which is just a county that keeps coming to mind for examples, always has the only give me 1 second to gather my thoughts, has the only psychiatry residency program in RCRC counties. There's only one place to go and get your psychiatric residency degree. There are 3 Masters of Social Work programs at Chico, Humboldt, and Monterey Bay. And then there are 4 certificate and 2 associate degree programs that graduated 112 students in 2021. That is not a lot. I think I meet 112 people in probably 2 weeks compared to the 2 million people who live in rural counties in California. So that's kind of comparison. And then kind of my last statistical discussion is where are these behavioral health providers? There aren't any educational institutions for psychiatric nurse practitioners or psychiatrists north of Sacramento. So to my point again, in order to go out and practice in these rural counties, you have to go to school somewhere in Sacramento or further south, get your life together, get your degree, and then move into rural counties. So that is also a problem because while you're in school, you're not building connections with the community you could potentially serve. And it's a very large, costly degree to move up and go to other counties. There aren't any doctoral programs in psychology in the Central Coast or in the San Joaquin Valley regions. And for the same reason as I mentioned earlier, it's really difficult to go get a degree and then have to move and practice. And then kind of a little bit of supply and demand discussion because I have to bring economics into it. LCSWs, psychologists, and psychiatrists will decrease in supply by 2028, and we will have 41% deficit or supply. There won't be enough to supply the need of psychiatrists in 2028 in California. And even though psychiatric technicians, licensed marriage and family therapists, and clinical counselors will increase in 2028, there will still be an 11% deficit for provider need. So that's really important to understand when looking at the scope of behavioral health care in California. Alrighty, another graphic because I love them. But I like to think about any kind of access to a resource or a need through the lens of acceptability, availability, and accessibility. Acceptability, is it acceptable to go and get this care? A lot of the time in rural counties, mental health care is stigmatized. Not everyone wants to talk about it or go get that care, especially if your neighbor knows where you're going at 11 p.m. on a Tuesday or 11 a.m., pardon me. And then availability, I think it's really important to look at the workforce shortage, but then look at the providers that actually take the insurance in these counties. Because if you put a provider in these counties and they don't accept your health insurance or they don't accept state-funded Medi-Cal, Medicare, whatever you want to call it, it doesn't do anything. It doesn't do any good. So ways to bring not only availability, but also accessibility, kind of tying into the last bullet point. Economic disparity. So looking at whether or not someone can actually afford to pay for their healthcare that's put in front of them. And then do they have broadband connectivity, or which Sam will get into later? And then transportation. I know it takes me maybe 15 minutes to get here from my house, but if I lived in rural California, it would probably take me 40 minutes if I had to go through windy roads to get where I need to be. So I just like looking at that visual, and it helps me kind of wrap my head around what I just told y'all. Will the clicker work? Cool. There we go. Alrighty. Why should government care? This graphic here on the right is a description of how many hospitals have closed since 2005 across the country. And if I did my counting correctly, California is in the top 10 with 9 closures since 2005, which doesn't seem like a lot, but if you live in a rural county and your closest hospital is 10, 15 miles away and that closes, you have to travel even further. So keep that in mind when you look at the statistic. And then just a couple more statistics. 1 in 6 adults in California struggle with serious mental illness. And of that 1/6 of the population, 1 out of 24 of them actually struggle to do their activities of daily living or to interact with society. Additionally, if we don't intervene with behavioral health issues, it can lead to much more complicated risks later on down the line, such as, most importantly, premature death, dementia, heart disease, stroke, substance abuse, all sorts of fun things, which not so fun. But there were also 2 hospital closures in 2023 in Madera and Corcoran, which, as I talked about here, if a hospital closes, you have to travel further in order to get care, which is really, really difficult, especially if you live in rural communities. And then just for cost analysis and economic purposes, I have to bring it back to it. The economic cost of untreated mental illness in the US is more than $100 billion annually, which is a lot of money. And the rate of unemployment of those with depression is almost twice as high as those without. So that also costs our government money, and it's important to take that into account when we analyze different alternatives. Alrighty, I keep saying already. It's one of my favorite words. So to guide our conversation, I think it's really important to put our train of thoughts into a structure. And we started by working with our client to define the problem and provide research and context and guidance to our policy discussions and our solutions. Then we assembled evidence, which I just went over, all of the background research, all of the things that helped us decide which alternatives would be important to discuss. Then we constructed our alternatives based on the research we just did, select our criteria, which I will go into later on down the line, which we chose cost effectiveness or efficiency, equity, and administratability. We will also project the outcomes of what will happen if we decide to enact said alternative, confront the trade-offs, and decide what solution does XYZ best and what it lacks, and if that's more important than the projected outcomes and benefits of solution B. We'll stop, focus, narrow, deepen, and decide, and we'll spend time working with each other, with our client, with other research, with facts, and kind of construct our final alternative, and then we'll tell our story and present our final alternative, which you will see at the end. Alrighty, so our graphic or our problem tree, again, just summarizes what I went over the last few minutes. It talks about how geographic barriers, access to insurance, the access to limited providers. A lot of the times with these rural counties, primary care physicians or PCPs actually provide this care. And so that's also important to take into account with the hospital closures and limited provider access. Lack of reliable both private and public transportation, lower education levels of those in these counties. So with lack of actual higher educational institutions, people have to leave their county to go get education and then return to provide care. Lack of investment in infrastructure, whether that's hospitals, education, roads, whatever you want to call it. And then that all leads to the giant problem of lack of access to mental health care. And then all of the outcomes that I discussed on a previous slide, from premature death to lack of representation in rural communities from providers to substance abuse disorder and things like that. Okay, so how do we evaluate everything I just told you and the alternatives that the rest of my team will present? Again, we focus on equity, efficiency, and administratability. We defined equity as the idea that we will give the most amount of resources, or as many resources as we can, to those 6 counties that don't actually have psychiatrists present. And then there's also 5 counties that have the lowest level of master's level clinicians. in their county. So we also group those in there and how those resources will be distributed to each county. You can read through the different 1 through 5 scale. Efficiency, or the biggest bang for your buck. How much money does the government have to invest, and what outcome does that create? Does it create 30 providers, 15 providers, XYZ amount of providers? And then administratability. How much infrastructure do we have to create in order to get this program done? Does it require a whole new structure of infrastructure, or does it work within existing systems to get the job done? So that is our rubric. And then they will also present a qualitative CAM, which ranks equity, efficiency, and administratability on high, medium, and low levels. They will discuss that further when they get to their qualitative CAM. And then a quantitative CAM, which is kind of the most important CAM in my opinion, because it allows us to actually see how we would numerically rank each alternative and present our final solution. So we decided to weigh equity at 50% and efficiency at 30% and administratability at 20%. So when they go through their quantitative CAM, they will give their alternative a ranking from 1 through 5, multiply that times the, weight of said criteria, and then get a final outcome. So I will go ahead and hand it on over to Jen to finish out alternative 1. Want the clicker? It's just, yeah, I think it's just that guy.
Okay, well, we'll find
Have
out.
fun.
Thanks.
I was gonna do it when we do alternative, or not our alternative, our discussion beforehand.
I could. I can tell.
Thank you. It's been a long day. So if you have any questions for any of us, if it's me speaking, feel free to just interrupt me, raise your hand, and I'll call on you. But if it's while any of them are talking, or you have kind of a question you can hold on to, feel free to raise your hand. They'll make note of it, and then they'll come back to you at the end. So does anyone have any questions for me? Nope. Already. Thanks.
Appreciate it. Hello, how's it going? Hope you guys are all having a good night. Thanks for being here, even though you had to be here, but I still appreciate it anyways, appreciate the support. So as you all know, and some of you may not know, my name is Jennifer Tovar, and I will be presenting alternative 1 for our problem statement. So alternative number 1 is for giving student, am I too loud? I feel good. Okay. For giving student loans for medical personnel specializing in behavioral health. So incentivizing current medical providers to relocate for employment in exchange for student loan forgiveness is the quickest and most efficient way of increasing access to behavioral health care in rural California. So of course, I'll dive a little bit deeper into this on the details and how I presume this to work. However, I think that we can all agree that student debt is a very high stressor in our country. And the idea is that this is a win-win scenario. So the providers that are being given the student loan forgiveness are either significantly released of their debt or fully released of their student debt in exchange for high need communities being given access to behavioral health care that they either 1, do not have already, or 2, are going to be getting increased care in terms of frequency and in terms of quality. No, okay. Yep. Can I just click it on here? Ah, there we go. That's okay. I could just come up and do that. All right, so my stakeholder introduction. Unfortunately, my stakeholder is not here at the moment, but she will be joining us shortly for our panel discussion. My stakeholder is one that many of you already know. but I will do the honor of bringing her to our conversation. My stakeholder is Trina Gonzalez. She is the Vice President of Policy at the California Hospital Association, and she is a faculty in the MPPA program here at Sac State. Some of her previous roles involve being the Director of Community Integration at UC Davis, Program Officer for Millbank Memorial Fund, and has extensive experience in California state government. Education and master's in public policy from Princeton, a master's in political science from University of Hawaii, and a bachelor's in international relations from Scripps College. I do want to take the extra moment to give Trina a bigger shout out. I had a little bit of just a discrepancy with my initial stakeholder who offered some really great support and information, but just because of the way the world goes and things happen, Trina was really awesome to step in and kind of help me out last minute, offer me her support and expertise in terms of my policy alternative, taking a look at my slides and kind of giving me her opinions on those things, especially during such a busy time since we're at the end of the semester. All right, so a little bit of research to get us going, because who doesn't love a good little bunch of research, you know? So here I have some stats regarding student debt. Hopefully you can see it's a bit small, but the UC versus the CSU system. So for both, about 30% of students take out some type of loan or do some form of borrowing in order to attend the school. The ranges of debt vary from, we could say, about 13 to 20,000 or so, pretty significant, especially if you tend on pursuing your education further, meaning you're working and going to school and just paying for regular life expenses on top of whatever type of loans and debts you're taking on in order to attend school. That can be very difficult. And I know in just personal experience, it can be a really huge stress on you. Um, and here we have couple more stats regarding schools that are for-profit, nonprofit, an even higher percentage of students borrowing with very large ranges of borrowing amounts, just depending on which college it is. Again, so just kind of pushing more the idea that taking out student loans is a really common practice in order to be able to attend school, and thus can result in high stress because of that. So a little bit of the problem, Maddie mentioned this a little bit earlier already, but just for the sake of my alternative, I kind of wanted to push it a little bit further. So workforce shortages in rural California. I know Maddie really honed in on the idea of a psychiatrist. There either being no psychiatrists at all or extremely small amount of them. Pushing the idea further in rural California, it's not just those people that have that expertise, it's just the whole range of medical providers and behavioral specialists. Because of this, we can see how vulnerable populations can be affected. In these rural areas, some of these populations can include minority populations, potentially single parents, and people that could potentially be involved in the foster system. That's okay. I kind of like walking around. Oh, thank you. Okay, so based on some already in place student loan forgiveness programs that I have researched, I came up with some criteria that seems to be pretty similar to theirs, although there's a couple differences, and I'll point those out. So number one, you must be a US citizen, US born or naturalized. Number two, this is the difference here. You must have paid at least 72 full on-time scheduled payments on your current student loan, which is equivalent to 6 years. Now, I want to stress the point that Similar to some other loans, and I'll share these programs later on. Usually the requirements start at 10 years of those said criteria, the full on-time scheduled payment. Now this one, I came up with 6 years, and I will get into why here in a second. Number 3, you must have worked at a NHSC approved site for at least 3 years. Now, an approved site can range from a lot of different things. Some of the examples can be if it's a United Indian Health medical center, but there is a wide range of hospitals to just regular medical centers that could fall under. And then number 5, the caveat is relocation to one of the top 20 rural counties in California for employment for at least 5 years. Now I chose 20 because though there are, other rural counties, the idea is that we want to get to the ones that have the highest need. And just a little side notes. Funding for this program will be brought to you by federal and state resources, just in case you wanted to know. Specifically the Health Resources and Services Administration. Kind of going back to this, the idea for number 2 here that you would only need to have paid on your loan for 6 years is because of where am I at? Woo. Pause, hold please. Is because of number 5. The commitment to relocation for 5 years is a larger commitment than what some of these other programs require. Usually it's only about 2 years of work in area of focus, whether it's a rural area or perhaps a certain work field, like something like social work, child welfare, family law, things like that. So because we're asking you to commit to a longer period of time, we're willing to accept you at less loan payments. If we, do the math, it could be about the same as, doing the 10 years worth of loan and then getting the couple years off, but it shaves off about a year or two, and can be more accessible for people who are still, 6 years in, still probably fresh out of school, or out of school, but still in early training and could really use that benefit. All right, so my logic model, sorry about that last one, it kind of cut off, but that's okay. So here, inputs, activities, output. So some of our inputs here would be funding allocated for this loan forgiveness program, the behavioral health providers who are eligible for loan forgiveness, so who fall under that criteria that I had mentioned, laws and policies that facilitate loan forgiveness and encourage it. Some activities that would contribute to this, designing the design of the loan forgiveness program, which I shared some of the criteria, as you could see, monitoring the quality of care for the patients that are being seen. So is the quality of care increasing how we want it to? Is it remaining the same? And just another one, implementing a clear and easy application process for people. Applications in general for anything are also very stressful, and can almost deter you from either filling them out at all or just postponing of when you actually do it. So the idea is to make this process very clear, easy, and accessible for the people who would qualify for it. Some of the outputs would be the total number of applications that we would receive for this loan forgiveness program, and number of medical personnel who actually end up relocating to these rural areas. Some outcomes. Ooh. Some outcomes that we could expect. Short term is the increased availability of behavioral health care due to the increased workforce. That's kind of, I feel like, the kicker there, because as humans, we don't really think about the long term right away. We want the short term, we want the results right now. We want to be able to see the fruit of our labor as quickly as possible. So that's the first one. And then long term, over time, we could hope to see improvement in healthcare outcomes in terms of quality health, again, due to the increased access of care. And then some of, where are we at? Oh, please. Another outcome I wanted to mention is reduced and or fully eliminated debt for providers. Again, of course, they may have other debt from other loans, but this could be a really, really big load off of their shoulders. So mediating factors for both of these things could, really put a damper on the party if it doesn't work out how we want it to. So inside the studio here, we would really need to focus on the marketing efforts to this program. We want to get the point across in a clear way that's easy to understand, but also attractive to the people we're trying to bring in. And then also the redistribution of state and government funds. It'll come from federal and state resources, so there may need to be some reallocation of these things. And as we all know, that can usually cause a bit of a hubbub. So this would be really important in order to make sure that we can fund this whole program to work how we want it to. Outside the studio, for outcomes there would be the continuous incoming applications for this program, and then the availability of infrastructure and resources that are currently in rural areas to be able to support the medical personnel who would be moving in. So things like housing, schools, if they have children, neighborhoods that offer basic services that they're attracted to. And then again, long-term funding, because we don't want this just to work for a little while. We want this to work for years to come. So a few other successful programs that we can look to that we know have done a good job. I'll talk about just a couple of them. They're here. Public service loan forgiveness. So if you work in government or for a nonprofit occupation and you have made 120 payments on your loan, you can be eligible for loan forgiveness. This one here, the NHSC, this was kind of one of the ones I had talked about earlier. It's loan repayment and assistance in exchange for at least 2 years of service. So their requirement for work is a little bit less, but the extended qualifications are a little bit more than what we're asking for here. So we talked about this a little bit already in the logic model, but some anticipated outcomes that we could expect would be retention and job satisfaction. So the idea is that we hope that these medical providers that are moving into these areas are liking where they work, that we're hoping that they are liking this change of environment, and that they want to stay longer than what's required of the 5 years. It could potentially boost local economies, bringing more people in, more people working means more people spending money and putting money back out. Potential career development for behavioral health professionals. So coming into these new areas, making connections within their workforce and potentially being offered higher positions than what they already have. And this could potentially even encourage others to either join the fields and eventually be eligible for loan forgiveness after they have made some payments. Or maybe they're already a few years in and then gain some interest in it. Again, the idea is an increased workforce is less instances of current professionals being overworked because the work is better balanced. Another and final anticipated outcome mentioned before, but the availability of consistent behavioral health care. Some benefits, again, sort of mentioned already, less or no debt is less stress and more money in your pockets for whatever you want, right? Community development, if we have a healthier community, people might be more intrigued to get together either at social events or just go outside and do more, talk more, they feel better, they feel good. It addresses the work shortages that are in these areas. Increased access to healthcare is equal to improved public health. And then it secures a healthy future for the community and any people that end up coming into the community, because again, we're kind of enforcing this constant state of quality care. So this is my quantitative CAM analysis. I rated student loan forgiveness a 4 for efficiency. I feel that this alternative would be able to reach most of these rural counties in terms of that choice of relocation to 1 in 20. I feel like provides a really wide range. So I feel like we'd be able to access more. For equity, for the 30%, I chose a 3. I think that we could work a lot off of what's already been done and what's already worked. However, I did take into consideration the reallocation of that funding. We may need to pull from other things in order to make room for this program. Administratability, I did rate a 5 because, again, we have already seen this be done before. We can really try to mimic all the good things in these programs that have been successful, and try to bring that here to have a program that's successful again in terms of quality care for the people that we're serving and lower debt for the people that are participating. All right, next, so high, medium, high, equity, efficiency, and administratability. A lot of these good things I already talked about. I felt a little necessary to also mention potential obstacles. I feel like you can't have a good argument if you can't recognize what the negatives could be and then be willing to work around those things. So equity, a potential obstacle, providers may be relocating away from family and support systems for an extended period of time. So that could be either a new or increased stress on them while they're working. Efficiency, a potential obstacle. Term retention is not necessarily guaranteed. It is the hope, and we hope that the program is a positive thing. So we hope to keep people, but we cannot guarantee that. I do want to mention a good thing about efficiency is we're utilizing the current workforce that we have. So we're not necessarily having to wait on new people to join the workforce. We're advertising this program to the people that are already in the workforce. So the hope is that we'll have, again, a quicker success, quicker way to measure if we're doing what we need to do. For administratability, again, we can look to structures of other forgiveness programs to ensure success. And a potential obstacle could be high due to hiring more staff in order to keep track of this loan forgiveness eligibility and that 5-year term of employment. So conclusion, kind of just to bring it all together, this is a win-win scenario for the providers. We have either no more debt or extremely less debt. For the public, they're receiving a higher quality behavioral health care and more consistently. It's efficient because we're utilizing the current workforce by advertising it to the ones who are already in it right now. And it's more attainable because it's been done before. We know that it works. And with that, I will finish up here and turn it over to my classmate, Monica. Let me try.
You have a clarifying question? Yeah. I have one clarifying question. If they would leave the county in those 5 years that it's supposed to be there, would they need to pay back all of their earlier loan payments?
Correct.
What does that mean? That compared to?
We could make a list of acceptance. I would be willing to bend a little bit on that. Well, earlier and maybe the trade-off is okay, you're gonna have to sign for 5 to 10 years to have us front with the cost, but it's probably
So with that, I might have the alternative for you. Okay, so hi everyone. Thank you for joining us tonight. Hopefully you all leave here ready to fight for rural counties for behavioral health, mental health services. My name is Monica Sepulveda. And my alternative is higher education partnerships for psychiatric workforce development. So I know that's a mouthful, and I will break it down on what that means and what that looks like. But before I do that, I want to thank my stakeholder, Eliza. There was a picture of her up there. It's not popping up, but Eliza's up here. Hey. So I want to thank Eliza for joining us today, stepping up and supporting our program. Eliza, I've worked with her for several years now. She most recently was promoted to associate consultant for the Assembly Health Committee. So I want to congratulate her for that and for being willing to come and support us in our program. Oh, there's her picture. We had to build up, okay? Okay, so I want to illustrate for all of you what does the psychiatry workforce shortage look like, and then scale it down to what it looks like in rural California. So these are projections from 2020, but 2020, we're in 2024. 45% of the psychiatric workforce in California will be retiring within the next decade. If that was a number in 2020, no, that's 6 years from now. So that means we will need about 6,515 psychiatrists to adequately provide access. For regional disparities, the Inland Empire and the San Joaquin Valley face the most severe shortages. Just to put that number into perspective, the Greater Bay Area has the highest concentration of psychiatrists for 25 per 100,000 population. The San Joaquin Valley has the lowest ratio with 7 psychiatrists per 100,000 population. So why do we have these problems? What are we seeing? Besides the psychiatry workforce aging out, we don't have enough people going into the profession to replace those who are retiring. Okay, so this statement was made earlier. There is no psychiatric residency program north of Sacramento. So all the red dots that we see here are psychiatry residency programs, and all the other space is counties that don't have one. So I want to take a look and see, but that's the big picture of psychiatry residency programs. So I want to go into what my alternative is, which is partnerships with higher education institutions for this workforce development in rural counties. So the example of a program that I'm going to point to is a very new program. They haven't had their first cohort start yet. Their first cohort set to start next month with 4 residents in their cohort. So the name of the program is Healthy Rural California Psychiatry Residency, and it's a partnership between UC Davis and Health Rural California, Inc. And they are going to be focusing on placing the psychiatrists in Butte County. And there's going to be a rotation between Butte County Behavioral Health, Northern Valley Indian Health, and Cedar Yuba Behavioral Health. And so this program, they want to build a culturally competent workforce for rural California. So they even include electives such as Native American mental health, addiction, psychiatry, trauma-informed care, and cultural psychiatry. Another big perk of this program is they pay for you to move there and be part of the program. Another part of this program is that they offer mentorship opportunities and research opportunities. And the intention is for these folks to go out into rural California and eventually stay there. And this example specifically in Butte County. Okay, so we have talked about the political acceptability of all alternatives. And with this alternative, we have a chance to leverage higher education institutions or the interests of the higher education institutions that, you know, we see UC Davis is doing this, and we have higher education institutions all around California. And as Maddie mentioned previously, the counties that have a psychiatry residency program have more psychiatrists. So other programs I want to highlight is UC Irvine / UC Davis, but I'll focus on UC Irvine. They have a Train New Trainees PNT, Primary Care Psychiatry Fellowship. And in this fellowship, they are training psychiatrists that want to be primary care psychiatric physicians, and it does help cover like the expenses of the psychiatrist residents that get accepted into the fellowship program. So using that kind of fellowship model and being able to partner up with a community organization such as UC Davis did, it gives an opportunity for these psychiatrists to also be able to work in rural California. Another model that I kind of look to, but though the focus isn't on psychiatry, the focus is on rural public health, is a program by UC Berkeley where they offer their students paid scholarships for them to focus on rural health policy. So this is something that the higher education institutions are interested in, they are looking in, so it brings political acceptability to it. Okay, my logic model. So I will step on this side to kind of explain what the logic process was. So we put in our inputs the community needs, the resources, the expertise that this type of partnership would offer. We add the activities such as the curriculum, the training, the placement, and we do research and we add innovation to it. The outputs would be trained psychiatrists that graduate with a comprehensive training. And we are able to establish those community partnerships. I think all of us can agree while we were researching, and I mean, like for my group, that sometimes in rural counties, the communities are just a lot smaller and a lot of people don't go to outsiders. They don't go to outsiders, which is also a key component of it being done through a community-led or partnership and coming in with a name of a higher institution that's already trustable for people to be kind of incentivized or be more motivated to participate and receive the treatment. Okay, so hopefully the outcomes is improved access to care, enhanced cultural competency, innovative interventions, and we are able to create a long-term sustainable workforce for rural California. So I'm going to go into the mediating factors because I need to step out of Delulu land. So like, this all sounds great. This all sounds great, but of course it's going to cost money. You need money to be able to do this, and you need institutional cultural leadership within these institutions. For, you know, the institutions to step up and say, we want to do this, they show they want to do this, but something more specific to benefit rural California. We would have to create the residency program structure there for, you know, identify hospitals, identify clinics where we could place the psychiatrists for them to do their residency program. And we would need students to want to do it. We would need student engagement. Some of the outside mediation factors or outside the studio would be community collaboration and engagement. And of course, again, resource availability, so money. Okay, so my qualitative CAM. Rating it with equity, efficiency, and administratability, I gave all 3 marks moderate, just because while it's very acceptable, and it has the potential of operating in all 11 counties, there still needs to be other logistics like identifying the schools and identifying the clinics and identifying like the hospitals to place the residency. So there's a high level of like administratability that needs to be done. And then that brings into question, like, can it be done in all 11 counties? And if it is, like, can it be done efficiently? Okay. And then for my equity cam, I gave it a 4.5. Efficiency, I gave it a 3. And administratability, I gave it a 2. So my overall total rating was a 3.55. Okay, so my conclusion. So hopefully I've convinced you that higher education partnerships would be a good, new, innovative idea to create a culturally competent psychiatry workforce in rural California. Any questions?
Well, good evening. How is everyone doing? Are we having a good night? So I'm going to start with a quick question, and because my alternative is amazing. Have you all experienced delays getting medical care? Please raise your hand if you have experience in delay getting your doctor's attention. I have. I definitely have. So again, my name is Beatriz Smith, and today I'm going to present to you an alternative that's going to bring the clinic to your back door. My alternative is a mobile clinic. What is a mobile clinic? It's a vehicle that has been converted into a clinic that provides services, and that it goes to the places where people work, live, and pray. Okay? So that's my alternative. See? I wanted to share a very amazing story of a mental health mobile clinic. These photos come from Rwanda. This mobile clinic was actually established because, as you know, Rwanda has experienced high amounts of trauma after the genocide that occurred in Tutsi. And the government partnered with European Union to establish the mobile clinic. They come monthly to attend, take care of, and give counseling sessions to the Rwandan community. And I want to start with one of the testimonies from one of the patients, how he has struggled with mental behavioral issues. His name is Mambo, and he said, I sometimes wake up with too much anger and rage. In some cases, I emotionally and physically harm my family members unwillingly because of my mental health problems. He adds that he has had difficulty in getting along with his neighbors due to his illness. So the government is aware that Rwanda has high amounts of trauma in their community. And since they have established this mobile clinic, has helped the community get better. I also want to express one testimony from one of the government officials that has expressed also satisfactory ratings in the community's well-being. He says, we have learned that mental health is an important aspect of social cohesion and reconciliation. Trauma healing is an essential element in preparing communities to get together. We are happy that this mobile clinic it will be much easier for mental health professionals to reach the communities and do their work in a very professional manner. Well, I want to say thank you to my stakeholder, Jeremy Pearsall. He is a contract manager at Rural Community Assistance Corporation. Thank you, Jeremy, for being here. He has over 10 years experience overseeing contracts that bring services to rural communities. He, in a previous role, was a public works coordinator. He also is an MPA graduate. Yay! And his hobbies is he loves soccer, and he coaches for his daughter's team. Thank you, Jeremy, for being here.
Thanks, B. It's like I'm happy to be here. And I did graduate with an MPA from Idaho State, so within the big sky.
Thank you, Jeremy. We'll have some questions for you at the end of the presentation. So mobile clinics have, many studies have shown that they're particularly being very successful at providing care for minority groups. In my research, that I have found out is people that have been actually gathered data, actual patients, they found out that mostly the majority of them have issues with higher barriers accessing healthcare. We know that they bridge gaps in access to quality care, and they usually help people that are being marginalized throughout the time, communities that have been very, very vulnerable. That includes minorities. We also know that they create new business opportunities. You can create partnerships with healthcare facilities that have been already in the county, or you could create also, there are a lot of mobile clinics that have been in partnership with universities, also private foundations. It encourages innovation and community engagement. We also know for a fact that part of the population that has been taken care of, one of the recent studies that I was researching, about 52% of the clients that were seen identify themselves as non-white. 40% of those identify themselves as Hispanic. And we know that the mobile clinics, usually when they reach out to communities, they reach out to community members that have been displaced. So displaced populations such as homeless, immigrant, migrant workers, the underinsured, and children of those families. We know that historically these groups are being disconnected from traditional healthcare settings like the big hospitals, and these type of populations require support in accessing healthcare. So as mobile clinics have been found to be successful at reaching particularly those communities that have been marginalized. I love history. Like digging into this was really fun. So these photos are very old, and I went back. I wanted to find out a little bit about the first mobile clinic, how this actually started. And this was funded in 1917 during the World War I. The first ever recorded mobile clinic that's out there, it's called American Red Cross Motor Corp. And what's even more amazing, it was composed only of women. Yes, we're awesome, right? You can see a picture of one of the members. The motor corps in the beginning was actually first it provided supply. So it traveled from, war areas to train depots, back and forth, medical supplies, but it also transported patients that were very sick, right? So it provided transportation for those men and women, men that were actually injured in battle. During the 1930s and 40s, we know that there was a big push for the government. It was the first time after the war that they pushed for mobile clinics to be sent out to rural communities. During the 1960s and 70s, there was a push for these mobile clinics to give a specific care in rural communities, which basically gave care to maternity, children, and also with dental care. Then we move into the 1980s and 1990s, where mobile clinics were specifically very popular, providing care for people that had HIV or AIDS, resources, medicine, anything in particular in rural communities. And now we move to the 2000s, right? We are bringing big change in technology. One of the biggest moves in technology that has been happening for mobile clinics is that we providing telehealth. So, you can basically go into the mobile clinic, getting with an iPad, and you get a specific counseling with someone that's not there. They could be in two counties, it can be somewhere far away, or, in the capital here in Sacramento. So you have really an opportunity to be connected. Well, before it was very hard. You had to physically, like them, right? You have to have a person that drive in to help you. Also, we found the newer mobile clinics have access to medical records. So you go into your computer, you'll be able to know like what hospital, what was the latest time that this person was taken care of. So mobile clinics have been advancing little by little since the beginning of time. And we really hope that in the future, they become more available for communities that really need it. I went into research very heavily about mobile clinics. There was this data very interesting that I found, which basically surveyed 811 clinics, and they participated in something called Mobile Health Clinics Map, which is a research for all basically gathered data for a lot of mobile clinics. And they found out that annually they do about 3,491 visits. More than half of their clients are women. Minorities are the majority of people that have been taken care of. Of the 146 clinics that they found data, 41 of those clients were uninsured. Some of them have public insurance, but most, the majority were low income. The most common services that they have found was primary care and prevention. And usually the organization affiliations is some are independent, some have university affiliations, and sometimes they're part of big hospital care systems. The financial support that has been found is that it comes majority from philanthropy, and a little bit less than half receive federal funds. So the implementation for behavioral mobile clinics, it could be very successful. We have seen here in my graph that mobile clinics market has been valued at 1.66 billion in 22 and is expected to expand a compound annual growth rate. So it could be a good business for someone who would want to invest in a mobile clinic. You want to have very successful implementing this because it's a behavioral mental health clinic. You want to have a community need assessment, develop partnerships. You will want to have a very strong mobile clinic design, prepare your staff and train to be able to be cultural and knowledgeable, bilingual. You want to use your resources. If there's some hospital in town, you would want to partner with them. You would want to create a relationship. You also want to find strong funding and sustainability that would continue providing services throughout the community, right? So either funding from the federal government, you can partner with foundations, you could also partner with hospitals as well to bring in the care. And you also want to have an evaluation of the work that has been done. But I'll go into more depth in the next slide. So this is my mobile clinics logic model. I would have like an input, which are all of the important activities that need to happen, right? So you would need funding, you would need human resources to help you with the mobile clinics. You would want to develop partnerships. For the main activities, you would want to create community outreach events. So you would go into the community, you would create educational sessions, community outreach, educating them, hey, we're going to have a behavioral mobile clinic. These are the days that we're going to show up. You would want to partner with an institution if possible, and you would want to park that vehicle in a centric place in the town. So near a park, near a church. You wanted to make sure that people are aware when we're coming, how many days we're coming. Then during that activity portion, you would offer counseling, therapy sessions, assessments, behavioral assessments. You would also offer medication referrals. You could partner with pharmacies in town, to provide the referrals as well. Then you would want to not just offer individual counseling session, but also group family therapy sessions. You would want to offer also telemedicine consultations. So the mobile clinic would not just come with one, you could come with one or two. You would have iPhones or iPads that would allow, multiple providers to be connected with community members. Let me see. You would want to have also collaborative care. So as I mentioned before, coordinate with local healthcare providers to create more integrated care. You would also want to have that relationship for referrals. Like, hey, this is our mobile clinic. Do you have any patients that you can refer to us? So in that way, we gather the information and do an educational outreach. And of course, you want to create data collection. And the reason of why you want to collect it is because you want to improve our resources. We never want to stay stagnant. We want to evaluate what we're doing. In that way, we're able to be better at what we do. Like, what is it that we need to do better or improve? So the outputs, of course, you will have an increased access to improve behavioral health care. You will have more screenings and assessments and counseling sessions. You will also have a collaborative care data collection. Then in outcomes, the goal of having a mobile clinic come to your town is that it improves the mental health, that it reduces the stigma, sometimes culturally, taking care of yourself, especially in my culture, is seen like you're weak. So we want to remove the stigma, right? You're not weak. Anybody could have behavioral mental issues. Everybody could have a bad day, right? And, you would do that when you come into the visits to the town. You would create areas where you educate the town and you let them know this is not a stigma. Just get rid of that. And then it's very cost-effective access. You could partner with current insurance, with Medicare, or any other public insurances that will be available. And the impact, you will create a community that has more health equity. You would give them empowerment, because when you feel better, you go out the door and it's a good day, right? And even medication, I think if some patients need it, it's very important for them to access them, right? A lot of people do not have the opportunity to access medications, and mobile clinics could provide that. For mediating factors, you would create, engagement, community engagement, and policy environments that shape funding partnerships is very important. Money is something that I'll get into it in a little bit, but one of the things that we really want to look into mediating factors is we must look into partnership with hospitals, universities that are willing to do the work. And I think philanthropy as well provide resources to basically be able to afford the costs that are coming up next. For mediating factors outside the studio, the patient engagement, the care coordinations, and access to support community resources really play a pivotal role in determining the success of the treatment plans and overall health outcomes. So costs. This is the average annual cost for operating a mobile clinic in the US is between $275,000 and $500,000. We have costs that are fixed, that we know for a fact that we can't really dismiss, right? There's personnel, you have your fuel, your maintenance, and your supplies. Mobile clinics are typically smaller size. They do require fewer resources, and there's an overhead expenses for staff. As a result, the operating costs are a little lower in comparison to the higher profit margins that a hospital would have. So this is my qualitative CAM. So I actually rank my mobile clinics pretty high in the overall score, because I do, through the research I've done, mobile clinics really are hitting the population that we're trying to help, right? The minority, the displaced, people that are being affected by not having enough resources to go to a traditional healthcare provider. In efficiency, I gave it moderate because it does require some monetary funding, right, to be redistributed from other programs. So either governmental or partnering with, for-profit or universities. And then administratability, I score it very low because it does require new infrastructure. You have to basically purchase a vehicle, convert it into a mobile clinic, or basically it's not something that you would have, right? You would probably have to purchase it. So that's why it's pretty low in administrability. And these are my numbers. So I have equity, I given a really 5 rank, and efficiency at 3, and administrability 1, just because we require new infrastructure to provide services. And then my overall score of 3.6. So in conclusion, I believe that you could access many people if you bring a mobile clinic to rural California. You increase this accessibility, you would provide timely intervention, you would create a customized outreach, right? But showing up to the community and tailoring services, either languages or training your staff. You would always want to collaborate with any local resources that are available. Provide always telehealth integration because it allows you to get more providers that come in that are not physically in the location. We want to create public awareness campaigns to make sure that the community is educated about the mobile clinic, and they always offer flexibility. We would always offer flexibility and adaptability, and of course, we would want to create policy support for my idea and create a more sustainable funding. That's it for me. Thank you so much. Questions? On national average. That I don't have, but I will get back to you with that one. Because for a fact, this is just to run it, right? The annual cost of running mobile clinic. I'll definitely can get you that data for sure. Thanks, Sam.
Okay, good evening, everybody. My name is Samantha Norgaard, and I am here tonight to bring you alternative 4, which is our final alternative of the night. And before I jump in, I just wanted to bring attention to, it is the month of May, so happy Mental Health Awareness Month. So this is kind of the perfect time to give this presentation. So just to dive in, my alternative is CPR3. You might be asking yourself, what does that stand for? And I'm really glad you asked. I'm going to tell you all about it. It stands for Connecting People to Resources. And so you'll see here my alternative statement. And there's the device. So we are going to utilize T-Mobile's CPR3 device to deliver essential behavioral health services to underserved counties in California, specifically rural counties, as our problem statement has already told you. This device is very unique. As I mentioned, it is powered by T-Mobile for government. T-Mobile, if you don't already know, has the fastest and strongest 5G network throughout the nation. So these phones do come equipped with that capability already embedded in them. And ultimately, the reason why I'm talking about this device to you tonight is because we'll kind of highlight these 2 little apps right up here. It's going to bring you telehealth. Specifically, you can call it telepsychiatry, you could call it telemental health, but that is ultimately the goal of this alternative tonight. And so I'm going to get into that a little bit more and why this device is so unique, why it's customizable, and why it's highly equitable due to those customizable features. and of course the 5G network that it comes equipped with. But before I get deeper into this device and how it works and what it's going to do for our rural communities, I would like to thank and recognize my stakeholder, who is Lloyd Levine, who happens to be here tonight. So can everyone just say hi, Lloyd? All right, cool. We're all awake still. Awesome. Perfect. So Lloyd wears many hats, as you can see on these multiple bullet points here. He is T-Mobile for Government's National Senior Executive for State Government Strategy. You must know a lot to get such a long title like that. Pretty impressive. But again, many hats, Senior Policy Fellow for Riverside School of Public Policy, a former California State Legislator, and he specializes in technology, as specifically broadband and bridging the digital divide and bringing broadband to those who need it most. And he is the author of Technology versus Government: The Irresistible Force Meets the Immovable Object. So thanks for being here, Lloyd. And thank you for helping so much with this presentation. I would like to give you some real-world examples about CPR3. It's actually being implemented amongst many populations already. So I did give you some examples here, and I'll kind of highlight the ones that stand out to me, although all very important. We have the Washington Department of Veteran Affairs. I like to point that one out because these are veterans who are using the program. So these could be folks of all various ages from different backgrounds, who might not have as much digital literacy as you and I might contain, and they are still able to utilize this device and access the features. Also, Iowa and Colorado have implemented and have delivered these devices for Afghan refugees. So these phones are highly equitable. They are, of course, technology these days. I'm sure none of you are surprised that they are multilingual. So they are able to help different individuals from various culturally different populations. And last one, just again, example in the real world, another way that these phones are being utilized to help folks is the NYC Health Correctional Health Services Department is actually giving these out to folks who've been released from Rikers Island. It's actually to help with reducing recidivism. So connecting them to the resources that are most important. Just to give you some real world examples. So just some quick client testimonials here. These are actually from the state of Washington. Department of Health Services gave these out to individuals with developmental disabilities. And I will just kind of highlight the first one is probably one of the most powerful ones on the screen. Ultimately, it did allow an individual using the phone to connect with 911. And also her case manager when there was a domestic violence situation. This might seem like we all can call 911. This is an easy thing for us all to access, but we live here in Sacramento. We live where cellular service is readily available, a lot of easy access to Wi-Fi. But again, we are targeting populations in rural counties throughout California where broadband is not easily or readily available, and cellular service might be lacking. So really being able to access 911 in a case manager can really affect and change someone's entire life. So I just wanted to highlight that one. And of course, you can kind of read through the others. Those are just some client testimonials of those who are currently using the phone or the device. So the design of CPR3, I'm going to kind of tell you how it works and how I think this could be implemented for our populations that we're trying to increase behavioral health care for. So I'll go over kind of what is the secret sauce. There is a lot of ingredients to the secret sauce in this device. Maddie mentioned at the beginning of our presentation this evening, there are 3 A's. So accessibility, availability, and acceptability. And I kind of want to start with the accessibility part. This device removes the geographic barriers. So as you can imagine, folks living maybe higher in the mountains, roads that become impacted due to weather, you are not going to get to your mental health provider. That is going to be a huge barrier to treatment. And this phone targets that exact barrier. So highly accessible, availability, these phones are available right now. We could give them to the hands of people who need them most right now today, if we were able to create that contract, which we'll get into a little bit more. And then I want to highlight acceptability, which some of my colleagues on my team have already really pointed out, and I find it really important to talk about acceptability, in that certain populations of certain backgrounds might have a stigma around mental health. To be honest, I think it doesn't matter where you come from or who you are, there's still a stigma in potentially being seen in a psychiatrist's office or a counselor's office. And so really the beauty of telemental health is that it creates this anonymous feature. It creates a lot of privacy and it creates a lot of comfortability that you can sit in your home and you can talk to somebody openly and honestly about some of the most vulnerable topics that you are going to talk about to anybody. So I think that is something that we really do need to highlight about telehealth and what it does and how it serves people, is the acceptability. And back to our list here, I noted wraparound services. So I am actually a caseworker. I'm in the social work field. So wraparound services, I immediately know what that is, but maybe not everybody does. Ultimately, wraparound can be various services that you need to access to have a fulfilled life, to thrive in life. So, and some of your basic needs. So housing, access to food, access to transportation, those things that maybe a lot of us have access to, but not everybody does. So we want to make sure that people, when we're targeting mental health, we're not just targeting access to a counselor or getting a psychotropic medication prescription. We need to make sure that they're living in a safe house, have access to good food, or know where to get resources to get more affordable housing or food. If they're a Medi-Cal recipient, do you know how to access CalFresh? This phone can be pre-programmed, as you can kind of see up there. And quickly, I thank you, Lloyd, for bringing an actual phone today. So maybe during break, you can all check it out. This is a currently one that's being used in the veteran program. And so it's really amazing to see how these apps are very customized to the population they're given to. So wraparound services are really huge and part of the secret sauce. Highly equitable, as I mentioned already, but I want to highlight again. It's a simplistic design. This phone can be used by anybody. You do not need to know how to use a smartphone. It's designed for those who might not be well equipped with that knowledge. And it comes multilingual features. So that is a big bonus for this device. Lack of broadband, no problem. This device comes equipped with 5G. It is unlimited data and it has a hotspot embedded into it. So that probably sounds good to some of us right now who are paying for that. This phone does come equipped with that feature. And something I also found through some research is it could potentially help make telepsychiatry and telemental health more normalized. If you were to get your iPhone, you go to Verizon today and you get a new phone. T-Mobile today, and you buy your normal phone, you want to upgrade your iPhone, right? And you go into T-Mobile and you see immediately it has a mental health button already pre-programmed into it. That's a pretty amazing feature, and it could help normalize and destigmatize just the act of seeking services. As again, a lot of my colleagues already mentioned, it can sometimes seem as a weakness to do this, but really it's a strength, and we have to kind of create the culture around that. And this actually device could do that. Who's going to fund it? Who's going to provide it? As I mentioned, T-Mobile is going to provide the service. Just to give you some numbers, $30 a month for the service, $5 a month for the Google suite of apps. So of course there are costs involved, as with everything in life. Those are them. Who could fund this? So I propose potentially Medi-Cal, potentially Cal-AIM, which is some innovative funding coming down the line, is an idea. The counties themselves could potentially be the administrators to get this program up and running immediately, as counties do actually have mental health departments already embedded in them. And for the software, in order to have the app on the phone, there are many companies out of the pandemic who have already created software that is sensitive to PHI, private health information. So that technology already exists. And of course, the device would support that technology. Logic model, we love these. So I won't go through every single box with you here. I think it's just a nice visual to see how this program would play out in the real world. Of course, your device right here is part of your input, your expertise. Of course, the contracts with T-Mobile, depending on what government agency, whether it's the county or state, that's going to fund the devices. Activities would be training those clinicians on how to use the device. And then, of course, outputs being we're getting more therapy sessions, potentially more psychotropic medication prescriptions, and outcomes and impacts, healthier California. One of the big impacts that some of my research, which I'll get to in a moment, really showed is that less ER visits and 911 calls. This phone can be really proactive for that and actually save a lot of money. Those visits are not cheap. And of course, the more sensitive topics would be less self-harm, potentially less substance abuse too. And there's some mediating factors that can affect all of this. Of course, nothing's in a vacuum. There are a lot of environmental factors. So of course, budget is a huge thing. I don't want to overlook that by any means. Surplus deficits within county technology budgets are real. And then of course, we're in a budget deficit right now. So implementing these brand new programs, some might not, some may be opposed to. But we'll talk a little bit more about that in a second. And some other mediating factors outside the studio. Sustainability, we want to make sure that these are taken care of, avoiding property destruction, and making sure that the workforce continues to grow. Someone has to be on the other end of these devices. So I do want to acknowledge that as part of the factor with providing telehealth. We do still need to grow our workforce. Research. Okay, we're data-driven here. And I just wanted to highlight a few things I found. May be not a surprise to any of you, but there's a lot of data that does support telehealth. The APA, the American Psychiatric Association, did show, and this was a couple years ago, so I would potentially say this number is higher, but nearly 6 in 10 say that they would utilize telehealth for mental health services. Also, the report that we did look so kindly that our CRC provided to us that they did in conjunction with the UCSF did note telehealth. Of course, they're targeting the workforce shortage, but telehealth is going to be one modality to potentially bring more people to the workforce. And just some other findings there is that the VA did a big cohort study that showed that veterans who were given these video-enabled tablets actually did increase their attendance with counseling visits, and these ER visits decreased. So really great data there. And telehealth has been shown to improve patient satisfaction and be cost-effective. That is from NAMI, that is the National American Institute for Mental Health. And they are big supporters of telehealth and have done some legislative work to make sure the funding is there and make sure Medicare and Medi-Cal cover telehealth. So cost and sustainability, I said, look to those who are already doing the work. I was really fortunate to have a conversation with a marriage family therapist. I work for Placer County, so that's one of our rural counties we're talking about. And I was able to talk with a clinician there and just to kind of pick her brain a little bit to see how mental county services really work. I'm in the IHSS realm, so I don't deal directly with mental health, but I do get to interact with the populations who could utilize these services the most. And I spoke with a clinician there named Jen, and she ultimately said that, and again, this is one county, but I think still an example, is that her team, she works for the mental crisis team, and they do actually go out in the community. It's 24/7 and deal with those emergencies and provide counseling and care. The problem, they cannot get to Alta or Tahoe. Placer is a huge county. There's a lot of rural areas that are very difficult to get to. I think just this weekend, 80 practically shut down. So it happens all the time. And these clinicians can't get there. I told her about CPR3, and she did seem very excited about this, as it would connect her to those people who need it most. Because currently right now, if someone in those areas do have a mental crisis or emergency, they are forced to call 911. There is no mental county provider who's going to be able to come out and geographically get to that individual. So I just want to acknowledge, yes, there are some upfront costs, but There's a lot of benefits that can reduce those negative externalities like costs ER visits and 911 calls. All right, getting into the fun stuff, qualitative CAM analysis. Excuse me. Equity, we ranked high for this. This can increase consistent, immediate access to behavioral health, to all 11 vulnerable counties that we identified, potentially to all 39 RCRC counties. Our efficiency here, we ranked medium, as it does require some monetary investment. It's not free. It does have some costs associated with it. However, it potentially does not require any new professionals just to jumpstart this program, which I think is a huge thing to highlight. And of course, I want to be objective and I want to have a critical thinking cap on, and I do want to acknowledge the burnout on the current workforce could be something to acknowledge and look into. Really what's great about the phone is that it can actually target efficiency, right? If you are a clinician, you can see maybe 10 plus people in a day versus if you're driving around in a rural county, you might be lucky to see 5. I personally do home visits. I do 3 max a day just because of the driving that it takes me to get up to Placer County. So efficiency, I do think there is a lot of perks to this phone. And administratability, we can utilize the current workforce to administer the phones and start conducting telemental health. So deployment infrastructure, it's already in place. We're not like building a whole new thing here. We're not inventing something brand new. So I do think administratability is quite high for this alternative. And just putting that into some quantitative forms here, we did the Likert rating at 4 for equity, 3 efficiency, 4 administratability, giving you that overall 3.7 score, which will kind of make more sense when we do a comparison analysis when Maddie gets back up here and wraps us up. But before I call her up, I just want to conclude some things. And I really want to make it very salient that CPR3 gives you more bang for your buck. So if you are bringing economics into this and you're doing a cost benefit analysis, yes, there is upfront costs, but the savings involved in this alternative are quite huge, potentially so large that I cannot calculate them. But upfront costs initially, long-term effects, very great. The payoff of having this more proactive device, connecting people, I want to highlight before I get off the mic here is that yes, getting connected to a psychiatrist and a mental health counselor is critical for your overall well-being, but just being connected to your family and your friends and those in your community is huge too. And this phone is going to allow you to do that. It's going to have a connection to all sorts of resources. And again, strengths, as I underlined here, there are many. Equity, it's administratable, it's easy, it's fast, the phones are here. We could give these out and you would have access to services. And it works well with our existing systems. So let CPR3 help bring the digital equity, digital literacy, digital identity to the populations your agency serves. And that is it for me tonight. Thank you guys. Any questions? Shoshana. Yeah, I think that's a great question. So my idea here would be tapping into the mental health providers at the county level already. So they do employ MFTs, clinicians, different practitioners. So fully utilizing them in their scope, because right now they're driving out to people. So ultimately, to be able to increase the visits per day, we could tap into that workforce. And I think you're right. I think you're definitely onto something there. Eventually, once this gains steam and popularity and the community is aware of it, I do think the county would have to potentially employ more people down the road. And I don't want to discredit our biggest issue here, which is the workforce. We do need to incentivize that. But if we're looking at something immediate right now, even to help 5 additional people in each of these more vulnerable counties, I think it's worth it to implement something like this. But it's a great question.
Is this
Yes.
really all 100% app-based, or can someone that simply has a child? It's two swaths of the state, 5G is still a dream. Far away, you're on copper line. So is it just, are we looking at just app-based? And is the telehealth mainly the modality of like video, or is it audio?
My understanding it would be video or audio, especially with the 5G connection. And I will be honest with you, I would have to float that question a little bit to my stakeholder as far as the 5G. I don't have that exact answer for you, albeit a good question. Maybe the panel, we can dive into it more. Yeah. But my understanding is yes, it would mitigate that issue with the connectivity. Any other questions, Maddie? All right, thank you guys.
All righty. I am going to see if the clicker works before I walk away from the keyboard. See if it works. Oh, it works. Look at that. Cool. Alrighty. So everybody just presented really cool alternatives and they all have their own benefits, but I like to see kind of how the different Likert scales and the CAMs kind of interact with each other. Our highest rated alternative would be loan forgiveness at a 3.9 per Jen's discussion about how easily administratable it is. It's easy to get people out there. We already have these clinicians in place. It's just forgiving their loans. Coming in second is Sam's alternative, CPR3. I think kind of the downfall is kind of what Sarah talked about and how administratable it is with current infrastructure in place. But then mobile clinics and increasing psychiatric workforce are kind of tied for third and fourth. And they both, or all 4 of my guests, have their pros and cons. We kind of decided that loan forgiveness is kind of our top choice, and we will explain why in just a second. Okay, now it's not going to work when I need it to. Oh, goodness gracious. Give me 1 second. Great. So I wanted to take a look and see if I changed the weightings of equity, efficiency, and administratability, if that would change what came out on top. I went ahead and decreased equity's percentage, I believe by 30%, if I'm remembering correctly, and efficiency I bumped up to 50%. I can't see off the top of my head. And then administratability I increased. So I basically decreased the value of equity and increased the other 2. And what was interesting is loan forgiveness still came out on top. But then, excuse me, CPR3 was in second, but the mobile clinics and the psychiatric workforce flip-flopped. And I think it's just really interesting to understand that when you change that in value, it actually changes how you view the alternative, but it didn't change our final recommendation. See if it works again. Nope. So our final recommendation is loan forgiveness. I think it does a really good job of putting providers in these counties quickly. It gives access to more hands-on care for clinicians or practitioners, as well as in-person behavioral health care for patients. And I think that's really important. Again, it weighs really high or ranks really high in administratability because there are already programs in place. And it is pretty equitable because you can determine where you send these people or these clinicians and all that kind of stuff. I'm going to scooch on back over here. This is going to annoy me, but I like to walk and talk. So is loan forgiveness politically acceptable? I say yes, and I believe the rest of my team does as well. There's a couple of reasons for that. First and foremost, Prop 1 just passed and it changed the Mental Health Services Act. So I think there's an opportunity there to change the funding in the Mental Health Services Act and increase funding for loan forgiveness if we choose to do it the way that Jen suggested or in other ways. I always cannot say Roman numerals correctly, so correct me if I'm wrong, but Title 9E I think is a really, 4, see, I got it wrong. There's my brain. And it's been a long day. Title 4E is already in place and it serves over 10,000 students in California. It's already working. It gets the job done, especially for behavioral health providers. And then I think it's important to note that President Biden is spearheading the movement for student loan forgiveness. If you watch the news, you know this. And And then a kind of local, more state level example is SB 909. I am not going to read the whole name of that, but it is a repayment program that removes the cap for providers who practice in certain areas and allows them to be forgiven, their loans to be forgiven for X amount of money. So I think that's a really stark comparison, and it allows you to see that this can actually be done if we do it right. Alrighty, in conclusion, I think that loan forgiveness is key in increasing access to behavioral health care providers in rural counties, especially for face-to-face care. I am a firm believer that if you don't build that connection in person, you're not going to get as much care and as much benefit from the care that you get if you get it in person versus online. Current legislation and the state mood allow us to actually make that step and provide the care to rural counties that we need. And there's already existing framework. So it can be done. It's just a matter of if we get there. And that is all I have. Does anyone have any questions for me? Yeah, go for it. That is a very good question. My thought process behind that is that argument is correct, but it also does shift funds. And so there's an opportunity to kind of have that dialogue and discuss how you shift funds. And I think the dialogue is already there. It's just how you shape that dialogue is really important. So not necessarily the arguments for or against, but the dialogue surrounding mental health care and access to mental health care is already there and already being discussed.
I'll just add part of
Got it.
Part of the money that was redirected from the locals to the state was to fund workforce development. So
Okay.
there's a new bucket for the state. So presumably,
Thank you for clarifying. I appreciate the help. Any other questions? Go for it, Rob.
Work for 5 years. I worry about it's gonna take 5 years. You know, that might not be a big enough encouragement. Somebody has to go there. You know, like they can go there and they would, their payments due for the first 5 years, reduced to half. Right, and then the loan forgiveness would be entirety, just to encourage people to make the initial move.
I don't know off the top of my head. I think that's a good point. To be honest with you, I think I'm a big believer in intersectionality. So I think all of these different alternatives can work together to kind of create the perfect program. But I do think, as someone who's in student loan payments, I think the idea of forgiveness is really beneficial, but how you get there is a whole different thing. And like maybe incentivizing them more, kind of per your point, might be beneficial. I don't know off the top of my head to answer your question. Jen, do you want to add anything?
Now, you're looking for public service for 10 years. Right, your loans are gonna be.
You're saying if they relocate for 5 years, having a portion of them forgiven, and then if they stay beyond that, then they have a chance to have a full.
No, they go right away and their loan payments are comfortably. Right, they don't.
I see before having to wait.
And then after 5 years, then they're entirely forgiven, right? I mean, maybe it could be 90% or 80%, doesn't have to be 50%, but it gives them that initial desire when they're coming out of school, you know, a choice to be in Sacramento or in Chico, my payments are gonna be up by 10 or 20%.
Well, I think that's the question I'd like to ask. In your research, did you guys find, and I'm not aware of them, but this is not my area of expertise, did you guys find any loan repayment programs that focused on location instead of field of study? And there's a big difference between we'd like you to be a social worker and we don't care where you do it versus, hey, you're gonna move to Barstow and you said something in your closing, we can decide where we put them.
Yeah.
No, you can't.
Okay.
You can't decide where you're gonna put anybody. You can try and provide an incentive, but somebody has to decide to move there. And I think that's the biggest weak point in the loan forgiveness program is you're trying to incentivize people to move where they probably don't want to move. Are there arts amenities in those communities? Are there museum amenities in those communities? The type of person who's going to go to graduate school is going to probably be higher intelligent, higher income. They might want additional amenities that are available in cities. So you're trying to provide an incentive that is counter to their probably human nature. Do you have student loans?
Yeah, I have a lot of them.
So if I offered you half off to move to Barstow, to work for Barstow City Government, would you do that? Sorry to anybody who's from Barstow, but.
Well, I've been to Barstow. They have an outlet mall, so maybe.
And the original Del Taco. I mean, it's a hopping
okay,
place.
do you watch Grace and Frankie?
I
I
don't.
did.
Okay, they are obsessed with Del Taco. If you haven't watched,
I've been to Barstow
But-
many times.
Okay.
The point being, maybe it's not hard. Could we provide an incentive for you to live somewhere that, would you move to North Dakota if the
I-
government had a great program?
So
You get the point.
I would say yes. But
Do you think there's enough people to fill the needs in this program? Yes, you can always find one person like, yeah, I wouldn't mind living there.
I
Can
would.
you scale this?
I would say one, the workforce crisis is so bad, honestly, as long as they're staying in public service, just give them loan forgiveness
yeah,
because it's atrocious, our workforce levels right now. And I think we need these people in every single public sector job. Now, I think how you make the twist of rural communities, the idea that you can get someone to move to a rural community and stay there for very long is not realistic. We understand that in terms of the doctors, you get your 4 or 5 year residency, and that's okay. We build our healthcare systems around that. For your marriage family therapists, your social workers, those that are typically employed by the county. Now, if you can put aside a bucket and say, this is a really large bucket and only rural counties can access this bucket for loan forgiveness, it helps us. If we get someone either from that community or that surrounding community in the educational pipeline, they're more willing to stay. So even having a stand aside that said, this is the bucket, it can only be used for rural communities, rural counties, and rural public sector healthcare providers can access that. And we can continually have those flows. I think that's where you have the incentivizing, because really you're protecting money for rural communities rather than trying to get students to move.